Shoulder pain is a common ailment, affecting millions of individuals worldwide. It can stem from various factors ranging from simple muscle strains to complex joint dislocations. Acute shoulder pain, characterized by a sudden onset, often arises from specific injuries and can significantly impact daily life, limiting mobility and affecting overall well-being. The shoulder, being one of the most mobile joints in the human body, is inherently susceptible to injury. Understanding the causes and mechanisms of acute shoulder pain is crucial for effective diagnosis, management, and prevention. This essay delves into the intricacies of acute shoulder pain, exploring the anatomical structures involved, common injury mechanisms, diagnostic approaches, and treatment modalities. By shedding light on this prevalent condition, we aim to empower individuals with the knowledge to seek appropriate care and navigate their path toward recovery. The shoulder, a marvel of biomechanical engineering, is not a single joint but a complex interplay of bones, muscles, tendons, and ligaments orchestrated to provide a remarkable range of motion. At the heart of this intricate system lies the glenohumeral joint, where the head of the humerus, or upper arm bone, meets the glenoid cavity of the scapula, or shoulder blade. This ball and socket design, while enabling extensive movement, renders the shoulder inherently unstable. Providing stability and control are the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. These muscles and their tendons form a musculo-tendinous cuff around the glenohumeral joint. The rotator cuff muscles act as dynamic stabilizers, controlling the movement and position of the humeral head during shoulder motion. They work in concert with ligaments, which connect bone to bone, providing passive stability to the joint. Understanding this complex interplay of structures is crucial for comprehending the mechanisms of shoulder injuries and their subsequent management. Shoulder injuries often announce themselves through a symphony of symptoms, each note hinting at the underlying cause. The location, intensity, and character of pain provide valuable clues for diagnosis. Pain originating from the top of the shoulder might suggest a rotator cuff issue, while pain radiating down the arm could indicate nerve involvement. The onset of pain provides further insights. Sudden sharp pain often accompanies acute injuries like fractures or dislocations, whereas gradual onset pain may point towards overuse injuries or inflammatory conditions. Mechanism of injury, the how and when of the injury, is another critical piece of the diagnostic puzzle. A fall on an outstretched hand might suggest a clavicle fracture or acromioclavicular joint injury, while repetitive overhead activities could implicate rotator cuff tendinitis or tears. Recognizing these patterns is paramount for guiding appropriate diagnostic investigations and treatment strategies. Evaluating shoulder pain is akin to detective work, requiring a meticulous and systematic approach. The clinical examination serves as the compass, guiding the clinician towards the source of the problem. It begins with a thorough history, where the patient's narrative about their pain, its character, and the events surrounding its onset provide invaluable clues. Physical examination follows, encompassing observation, palpation, and assessment of range of motion. Visual inspection reveals any obvious deformities, swelling, or bruising. Palpation, the art of feeling with the hands, helps identify points of tenderness, muscle spasm, or joint instability. Range of motion testing, both active and passive, assesses the shoulder's mobility in various planes, revealing limitations or pain provocation patterns suggestive of specific pathologies. Special tests, designed to isolate and stress specific structures, further refine the diagnosis, allowing the clinician to pinpoint the root cause of the shoulder ailment. Section 5, Clavicle Fractures, Navigating Breaks in the Collarbone. The clavicle, or collarbone, is a slender S-shaped bone that acts as a strut, connecting the arm to the axial skeleton. Its exposed position renders it susceptible to fractures, often resulting from direct blows or falls on an outstretched hand. Clavicle fractures are common, accounting for a significant percentage of all fractures. Clinical presentation typically involves pain, swelling, and tenderness over the fracture site. A noticeable bump or deformity may be present, and patients often report difficulty lifting the arm due to pain. Management of clavicle fractures depends on the severity and displacement of the fracture. Non-displaced fractures are often managed conservatively with immobilization using a sling or figure-of-8 bandage, allowing the bone to heal naturally. Displaced or comminuted fractures may necessitate surgical intervention to realign the bone fragments and stabilize the fracture, facilitating optimal healing and restoring shoulder function. Section 6. Acromyoclavicular joint injuries, separating fact from fiction. The acromyoclavicular or AC joint, where the clavicle meets the acromion process of the scapula, plays a crucial role in shoulder movement. AC joint injuries, often termed shoulder separations, commonly result from direct blows to the shoulder or falls onto the outstretched hand. These injuries are graded based on severity, ranging from mild sprains to complete ligament tears. Grade 1 injuries involve minor ligament stretches, while Grade 3 injuries indicate complete tears of the AC and coracoclavicular ligaments, resulting in significant joint instability. Treatment for AC joint injuries is tailored to the grade of injury. Grade 1 and 2 injuries are typically managed conservatively with rest, ice, compression, and elevation, followed by gradual range of motion exercises and strengthening programs. Grade 3 injuries may necessitate surgical intervention to stabilize the joint and restore normal biomechanics, especially in active individuals. Section 7. Rotator cuff, tears, navigating tears in the shoulder muscles. The rotator cuff, a group of 4 muscles and their tendons, plays a pivotal role in shoulder stability and movement. Rotator cuff tears, involving partial or complete tears in these tendons, are a common cause of shoulder pain and disability, particularly in individuals over 40. These tears can result from acute injuries, such as falls or direct blows, but more commonly develop gradually over time due to repetitive overhead activities, overuse, or age-related degeneration. Symptoms may include pain, weakness, and a catching sensation with shoulder movement. Treatment for rotator cuff tears depends on the size, location, and chronicity of the tear, as well as the patient's age, activity level, and symptoms. Conservative management, including rest, physical therapy, and corticosteroid injections, may be effective for partial tears or in less active individuals. Surgical repair, often performed arthroscopically, aims to reattach the torn tendon to the humerus, restoring shoulder function and relieving pain. Section 8. Imaging and Diagnostic Tools, Unveiling the Secrets Within. While clinical examination provides valuable insights into the nature of shoulder pain, imaging studies play a crucial role in confirming the diagnosis and guiding treatment decisions. X-rays, the workhorse of musculoskeletal imaging, are often the first line of investigation, particularly for suspected fractures or dislocations. Ultrasound, a non-invasive and readily available imaging modality, utilizes sound waves to visualize soft tissues, making it particularly useful for evaluating rotator cuff tears, tendinitis, and bursitis. Magnetic resonance imaging, or MRI, the gold standard for soft tissue imaging, provides detailed anatomical information, aiding in the diagnosis of subtle fractures, ligament injuries, and rotator cuff pathology. These imaging modalities, in conjunction with a thorough clinical examination, provide a comprehensive picture of the shoulder pathology, enabling clinicians to tailor treatment plans to the individual needs of each patient. Section 9. Conclusion, a path to recovery, tailored treatment for shoulder pain. Acute shoulder pain, often debilitating and disruptive to daily life, requires prompt recognition, accurate diagnosis, and individualized management strategies. Understanding the anatomy of the shoulder, recognizing the mechanisms of common injuries, and employing a systematic approach to clinical examination are paramount for effective diagnosis. Imaging studies such as X-rays, ultrasound, and MRI provide invaluable insights into the extent of the injury, guiding treatment decisions. Treatment modalities range from conservative measures like rest, immobilization, and physical therapy to surgical interventions aimed at restoring joint stability and function. The key to successful management lies in a tailored approach, considering the individual needs of each patient, their age, activity level, and overall health status. A collaborative effort between the patient, clinician, and rehabilitation specialists is essential for optimizing outcomes and guiding individuals toward a path of recovery, restoring their shoulder function, and improving their quality of life.